today about the ethics and legalities of telehealth. I hope not to bore everyone on the first day of the conference, and that too during an early morning slot with issues of a regulatory nature. Some people say that regulatory law is rather boring in comparison to the practice of medical malpractice litigation, but I must express that I enjoy the best of both worlds and the worst. There are a few reasons why telemedicine, like everything else in this world, has attracted some degree of criticism. Call it patient hesitancy or averseness in certain instances, or healthcare practitioners being extra cautious, understandably so, having regard to the nature of the doctor-patient relationship which arises. No doubt we will hear this for many years to come, but it was never completely envisaged that the COVID-19 pandemic would alter the manner in which we lead our lives on a day-to-day basis, let alone for a period in excess of 18 months. Information technology has no doubt revolutionized the practice of medicine within a very short space of time. I intend to speak to you today about telemedicine in the regulatory context, as it was pre-COVID, the general ethical guidelines for good practice of telemedicine as issued by the HPCSA, or the Health Professions Council of South Africa in 2014, the guidance notes issued by the HPCSA following COVID-19 being declared a worldwide pandemic, that is in March and April 2020, and then the subsequent media statement issued by the HPCSA in April 2020. And I hope that in doing so, I can shed some light on the stance adopted by the HPCSA regarding the practice of telemedicine. I also intend to speak to you about the World Health Organization's approach to telemedicine, and then very briefly what steps medical suppliers and healthcare practitioners have taken to make healthcare more accessible to patients. What the regulations also say regarding medical devices in South Africa, all in the context of ethical and professional considerations. I'd like to present my screen now so that you can see my slides.
Natasha, you should be able to share your screen.
Yes. So essentially, the World Health Organization defines telemedicine as the delivery of healthcare services where distance is a critical factor by all healthcare professionals using information and communication technologies for the exchange of valid information for the diagnosis, treatment, and prevention of disease, and the exchange of valid information for diagnosis, treatment, prevention of injuries, research, and evaluation, and for continuing education of healthcare providers, all in the interests of advancing the health of individuals and their communities. Telehealth is referred to as services provided by healthcare professionals in general, including nurses, pharmacists, and other healthcare professionals. So is there a difference? Basically, it is noteworthy that the two terms are used interchangeably to a large extent, and other terms are used as well, such as digihealth, e-health, telematics, which all describe the delivery of healthcare services electronically, to include e-health and telematics and the like. In essence, distance must be a contributing factor. Telemedicine or telehealth involves services being rendered by all types of healthcare professionals, and it is provided by means of information and communication technology, its aim being the diagnosis, treatment, and prevention of diseases and injuries. It also involves education of healthcare practitioners, and so it includes the provision of clinical and non-clinical services. If one has regard to the 2014 guidelines, on telemedicine issued by the HPCSA. Despite healthcare law being highly regulated in South Africa, there is presently no legislation or regulations issued by any act or under any act which deal with telemedicine in South Africa, meaning that there are no laws or regulations that have been enacted in terms of any legislation issued or any act by Parliament. What we do have is the position is set out in the general ethical guidelines for the practice in telemedicine, which were issued in 2014 by the Health Professions Council of South Africa, or the HPCSA, which is the statutory body which is tasked with regulating issues of this nature in terms of the Health Professions Act. The position as it was regarding telemedicine back in 2014, according to the guidelines, states basically as follows. At the very outset, it states that the practicing as a healthcare practitioner or a professional is based upon a relationship of mutual trust, which healthcare professionals and patients establish. The guidelines are aimed at creating the ethical standards for the practice of medicine. And the guidelines refer to the South African telemedicine system, which was issued by the Department of Health in 1998, which deals with delivery of healthcare services to communities that are situated in underserviced areas, more particularly in referring to women and children in these rural areas. It is important to note that the objective of the system was intended as a tool to improve access to healthcare services in South Africa, with various provinces participating in pilot projects. In KZN, for example, antenatal tele-ultrasound screening and tele-ophthalmology were pilot projects which sought to test the effectiveness, the efficacy, the benefits of telemedicine before the project was to be rolled out any further. The project was to be implemented in 3 phases over a 5-year period. According to the document which was issued by the Department of Health, telemedicine equipment was designed to support the various clinical applications at the different public hospitals in the provinces. But what is clear from the 2014 guidelines is that telemedicine services were actually intended to be offered to a patient following a face-to-face consultation and a physical examination of the patient in the clinical setting. A distinction is drawn between the consulting practitioner and the servicing practitioner, the former being the healthcare practitioner who consults with and examines the patient, and the latter being the healthcare practitioner who then renders services or follows through with those services. The rendering of services in terms of the guideline includes the offering of advice, intervention, and information to patients from a remote facility or location. Reference is then also made to the World Medical Association and their distinction between the two. And it would appear that one fulfills the role of the primary healthcare provider and the other the secondary healthcare provider. And furthermore, treatment and advice is actually followed through on the instructions basically of the primary healthcare provider. So telemedicine in the 2014 guidelines is defined as the practice of medicine using electronic communications, information technology, or other electronic means between the healthcare practitioner in one location and a healthcare practitioner in another location for the purposes of facilitating, improving, and enhancing clinical education and scientific healthcare and research, particularly to underserviced areas in the Republic of South Africa. So it appears from the 2014 guidelines that telemedicine services is to be provided electronically between healthcare practitioners in 2 separate locations in order to facilitate training and education, and more so in underserviced areas. At least that was initially the objective of those guidelines. Further, The 2014 guidelines state that platforms such as video conferencing can be used instead of face-to-face consultations between healthcare practitioners and patients. So telemedicine services therefore include in-person consultations and examinations online or on a virtual platform being delivered to patients. And the 2014 guidelines further seek to encourage continued education in the practice of medicine between healthcare practitioners, which obviously could not be compromised. But what is important also to note for the purposes of clarity in the context of those 2014 guidelines is that the 2014 guidelines also defines the requesting patient, who is the patient who requests to be treated by the servicing healthcare practitioner. And this applies only where there is already an existing healthcare doctor-patient relationship between the patient and the healthcare provider. When the 2014 guidelines were issued, they were not issued in contemplation entirely of COVID-19 becoming a worldwide pandemic, even though the idea of the South African telemedicine system and the 2014 guidelines aimed at making healthcare services more accessible to those who were not within close proximity of healthcare facilities and healthcare professionals as well. But I think one can say that nobody would have predicted the exaggeration of COVID or the extent to which it would have persisted, and it continues to persist to this day. Various issues were outlined in the 2014 guidelines, including the competence, the registration, authorization of healthcare providers, and the services that were on offer. In terms of the 2014 guidelines, mere completion of an online questionnaire was not sufficient or acceptable alone. Informed consent should be obtained from the patient. And what informed consent meant for purposes of telemedicine and the practice of telemedicine is that in addition to having a conversation with the patient during which the patient is informed of the options, the risks, benefits, the consequences, and well, the patient being afforded the opportunity to ask questions, informed consent to telemedicine required disclosure by both the consulting and the servicing healthcare practitioners of the types of electronic means or mediums via which the services would be provided. So it places a duty on the servicing healthcare practitioner to decide whether the condition can be diagnosed or treated as telemedicine in the circumstances. Security measures must be in place to ensure that there's password protection, data encryption, risks to confidentiality of patient information, express consent to transmission of that information to healthcare professionals over electronic means, as well as to third parties, are all required for purposes of complying with the guidelines to practice telemedicine. So as such, the delivery of healthcare services through the use of telemedicine imposes additional requirements for purposes of obtaining informed consent from the patient, and this is set out at length in the 2014 guidelines. Then further issues that are dealt with in the guidelines include routine, specialist, and emergency telemedicine services. These are also dealt with very briefly. Routine services would include patient-initiated or second opinion telemedicine only where there is previously existing healthcare practitioner-patient relationship. Telemedicine is used as an adjunct or as an assistive means actually to the practice of normal medicine, with telemedicine only replacing face-to-face consultations where quality and safety of the patient are not compromised. Then specialist telemedicine services would include those, actually the bulk of telemedicine services which were envisaged, if you will remember, in the 2014 guidelines, involved specialist services and then treatment that is not really easily accessible to those in the rural areas. With regards to emergency telemedicine services, those are services which are provided to stabilize the patient or where there is insufficient information relating to a patient at the time of the emergency. And once the patient is stabilized, the patient is then referred to a primary healthcare practitioner or a facility for thorough medical care. Record keeping of patients is also focused on to a large extent in the 2014 guidelines, understandably so. This would be of significance given that services are being rendered on a virtual platform. So having regard to what is set out in the 2014 guidelines, I would say that it is abundantly clear that the 2014 guidelines were issued as a means of providing healthcare services to those not within close proximity of healthcare facilities, and healthcare practitioners making themselves more accessible or available, and that too with a view to providing specialist healthcare treatment. So in terms of the 2014 guidelines, telemedicine services are possible where there are face-to-face consultations. And this has already happened, bearing in mind the objectives of the services and what they aim to achieve, and that the 2014 guidelines were drafted pre-COVID, prior to the outbreak of COVID, that is, at a stage when none would have envisaged completely a worldwide pandemic that would see most of the world living under lockdown restrictions for or to the extent that this has already occurred. Then we look at the HPCSA guidelines, or the guidance note, which is the 2020 March issued guidance note, which was issued following the outbreak of COVID-19 being declared a worldwide pandemic. HPCSA issued this guidance note in which it was stated that to further prevent the spread of the virus, self-isolation and social distancing were key. But having regard to the fact that healthcare practitioners were, of course, expected to continue providing healthcare services on an ongoing basis to patients, and they had to remain accessible despite the outbreak of COVID-19. And that was also in terms of the 2014 guidelines issued on telemedicine. The HPCSA issued further guidelines to be read in conjunction with the 2014 guidelines. The following guidelines, which are of relevance in the current context, were issued in March in the 2020 guidance note. In the guidance note, the definition of telemedicine was replaced with telehealth, which include the provision of telemedicine services, telepsychology, telepsychiatry, and telerehabilitation. The definition was actually amended to include remote consultations using telephonic and virtual platforms as a means of consultation. Of importance, I think, is that there already had to be an established doctor-patient relationship, except in circumstances where telepsychology or telepsychiatry services were actually being offered. The healthcare practitioner could, at their discretion, decide that the patient in question actually required a face-to-face consultation. And it is stated further in the 2020 guidance note that was only applicable for the duration of the COVID-19 pandemic. So the guidance note and was issued was applicable in that context, and it would then cease to apply after the end of the pandemic. Moving on to the next slide. Following the issue of that 2020 guidance note, the HPCSA then issued a media statement, and this was having regard to the increase in the demand for healthcare practitioners who were in the position to render telehealth services in terms of the resources and the skills, and the growing concern that telehealth services would result in the norm rather than the exception. The further media statement was issued and the position was further clarified. The requirements for the practice of telemedicine then, and the objective behind its practice, was that telehealth should be used as a tool, which is to bridge the gap between rural and specialist healthcare, and the practice of face-to-face healthcare should not be replaced with practice of telehealth, and this was further emphasized in the media statement. Further, the requirements for the practice of telehealth in accordance with the HPCSA prescribed ethical and professional standards were reiterated as set out further. Basically, ethical and professional standards need to be maintained at all times, even during remote practice of medicine. It then also dealt with registration of consulting and of the servicing healthcare practitioners as defined, and as I told you earlier, in the 2014 guidelines. Formal informed consent, more specifically with reference to diagnosis, prescription of medication, and information technology equipment. So that was an add-on in addition to what was provided for initially regarding to, with regards to informed consent. Patient confidentiality was also highlighted. The responsibility of the consulting healthcare professional was set out, and the issue of patient record keeping was then also further emphasized. Then came the issue of the HPCSA guidance note of April 2020. In light of the challenges that we're faced with COVID-19 and the fact that the 2014 guidelines were aimed at making healthcare more accessible to patients, the requirement that there be an existing doctor-patient relationship in all circumstances prior to telehealth services being provided, other than those which I referred you to earlier, attracted more criticism. In fact, it attracted great criticism in that it was said to have had the effect of defeating the purpose for which the March 2020 guidance note was issued for all intents and purposes. Concerns were raised that the relaxation of the 2014 guidelines in circumstances where the doctor-patient was a relationship was a prerequisite for the provision of telehealth services did not alter the position any further, in that those patients and healthcare practitioners who did not already have an established doctor-patient relationship could not benefit from telehealth services, more so in light of the fact that the March 2020 guidance note confirms that social distancing and self-isolation are necessary to abate or to prevent the further spread of COVID-19. So for this reason, the April 20 further guidance note was issued, which then referred to the President's announcement regarding the rollout of screening, testing, treatment of those who were situated in rural areas for purposes of determining who required in-hospital treatment and who could stay at home and treat themselves by self-isolating. The March 2020 guidance note was then amended to say that telehealth should preferably be practiced in circumstances where there is an already established doctor-patient relationship, but where such a relationship does not exist, practitioners may still consult using telehealth, provided that such consultations are done in the best clinical interests of the patient. The World Health Organization has issued a number of documents on telehealth, or what it refers to as e-health or digi-health or telematics. In its global strategy on digital health, 2020 to 2025 document, but the WHO encourages the implementation of e-health. It is stated in the strategy document that more than 120 member states, which include low and middle income countries, have developed strategies and policies which are in line with the WHO's papers or documents that have been issued on telemedicine. Various sources were consulted to develop a strategy on the implementation of e-health through a collaborative process, including public forums, consultations with technical experts, the United Nations General Assembly, and the World Health Organization, World Health Assembly, just to name a few. And no doubt, it has been acknowledged that the implementation of digital health might prove to be disruptive. However, the development of technology to include virtual care visits, remote monitoring, big data, artificial intelligence, blockchain, smart wearables, data exchange tools have all had the ability to improve continued healthcare and the potential also to improve diagnosis, clinical trials, self-management of care, and to create a better healthcare environment to those by providing evidence-based knowledge, skills, competence for professionals in the healthcare sector. It is stated further that some countries have made considerable progress in the development and implementation of e-health, while many others actually remain behind or in need of support in terms of resources and capabilities. The WHO, in its interim guidance note dated 7 May 2021, states that there's been a worldwide need to reduce face-to-face consultations by the provision of telehealth services, which requires collaboration between the private and public healthcare sectors, and the implementation of policies, legislation, and regulations for purposes of continued and coordinated healthcare. In doing so, this can result in somewhat of a digital divide, which leaves those for whom telemedicine guidelines were initially aimed at benefiting, that is, those in rural areas, more so women and children, and who are not within close proximity of these services, as well as healthcare practitioners left behind, basically, for which reasons special consideration must be given to mobile, migrant, rural, vulnerable people, and those with disability. But how this will be achieved is yet to be seen, and it would appear that the South African telemedicine system would have to put into motion what is set out in its document. The framework has been created, it's been established for the provinces, but what is required is, of course, a reconsideration of the position, having regard to how long ago those guidelines or that document was issued, and then, of course, the funding of resources, the equipment that is required, upskilling of healthcare professionals, that is to name a few things. Of course, the focus being on funding, which is the most important and concerning issue. Needless to say, a number of steps have been taken by healthcare facilities and healthcare practitioners to equip themselves to make healthcare more accessible in the form of information technology, which will ensure patient confidentiality on an ethically safe and professional platform, as well as education and training, not only for purposes of improving such services, but also with a view to continuing with medical research, which remains imperative at all times, more so in light of the COVID-19 pandemic. The COVID-19 pandemic has resulted in innovative technology, more so health technologies being developed, and medical devices being manufactured for patients with many types of illnesses, including those with chronic illnesses and diseases. Many of these devices are unaffordable to a large extent, and in many instances unsuitable for low or middle income countries. However, these devices, as approved by the WHO, have made healthcare more accessible. The WHO has provided an undertaking to work with funders, manufacturers, also with governments, and to make these tools and devices more accessible. The idea being for users of these tools and devices, achieving better outcomes and managing their illnesses in a more effective and efficient manner. Some examples include, well, portable respiratory monitoring systems, ventilators with extended batteries where electricity is not available or it is unstable, and solar-powered oxygen concentrators to treat illnesses like pneumonia. Of relevance is that COVID-19 has seen the use of home dialysis systems or machines in those patients who are good candidates, of course, for home treatment. These patients present with more comorbidities. In certain instances, it is said to have reduced the need for in-hospital treatment of patients and has proved to be more cost-effective, it is said. There is now also less hesitancy on the part of both patients and healthcare practitioners to make use of these innovative technologies, and therefore there has been an increase and a demand for these devices and these innovations in technology. The WHO approved devices are subject to an in-depth assessment of the use of technology having regard to the WHO specifications, issues such as affordability, the ability to use these devices with ease and comfort, and are subject to regulatory approval. With regards to the position as it stands in South Africa, the following applies. The South African Health Products Regulatory Authority, which is SAHPRA, remains responsible at all times for the monitoring, evaluation, regulation, investigation, inspection, registration, and control of medicines and medical devices in South Africa. In considering whether or not to approve these medical devices, SAHPRA will consider issues such as safety, efficacy, quality, and performance of these devices, as well as whether national and international standards have been complied with. I think what is of relevance, and I did see a number of questions being asked earlier regarding the position concerning the approval of devices in South Africa, is that pre-market authorization will be beneficial in medical devices gaining approval in South Africa, where there is originating approval, for example, by the FDA, the EU member states, as well as the WHO. Approval may be obtained on a more expedited basis, having regard to the fact that an accredited body has approved the device. As we saw also with the approval of the COVID-19 vaccine, which was approved on an expedited basis by SAHPRA once a certain phase of the clinical trial had been completed. It is important to note also that no medical devices can be manufactured, imported, or sold without a SAHPRA license. So just to recap on the practice of telemedicine in South Africa, having regard to what has been set out in the 2014 guidelines, the March and April 20 guidance note, and then the subsequent media statement issued by the HPCSA, the practice of telemedicine or telehealth is permissible in circumstances where it is practiced to prevent or abate the spread of COVID-19, and provided that it is in the clinical interests of the patient, and bearing in mind that there is no one-size-fits-all approach. The 2014 guidelines, as I said, attracted criticism in circumstances where those guidelines were drafted in an attempt to achieve a specific outcome, that is the accessibility of specialist healthcare treatment by those who were not situated within close proximity of those services. The position appears clearer following the issue of the guidance notes and the media statement by the HPCSA. In South Africa, the practice of telemedicine has not been discouraged. Many seem to have the opinion or be of the view that it is discouraged, but an emphasis has been placed on ensuring that the practice of telemedicine be implemented with a view to preventing the further spread of COVID, having regard to the clinical interests of the patient. And one must bear in mind at all times, of course, that the doctor-patient relationship, which is based on trust or confidentiality, must be maintained at all times. The relationship, once established, creates a duty on the healthcare practitioner or the doctor towards the patient, which is recognized in law. Due to the nature of the practice of telemedicine, it is imperative that healthcare services be provided in circumstances as set out in the HPCSA issued guidelines. A failure or neglect on the part of a healthcare practitioner to comply with the duty that is imposed on the basis as set out and as required in terms of the doctor-patient relationship could result in a complaint being lodged against a patient with the HPCSA, with a healthcare practitioner by a patient with the HPCSA, and where a patient institutes a civil action against a healthcare practitioner, it could render a healthcare practitioner liable for damages. A healthcare practitioner, we must also bear in mind, is also not exempt from being charged criminally. With regards to the future of telemedicine, it is highly likely that it will be offered as an option going forward in those instances where distance is a factor, where patients are immunosuppressed and at a higher risk of contracting COVID or other diseases or illnesses, or where a follow-up consultation with the healthcare practitioner is required, but it does not actually necessitate an in-person visit to the healthcare practitioner's rooms. Following the COVID-19 pandemic and its impact on human beings and the economy, as well as the fact that other strains of the virus have surfaced and there are other types of coronaviruses which could possibly result in future pandemics, many healthcare facilities and healthcare practitioners have modeled their businesses to provide telemedicine on virtual platforms. In addition to those issues concerning professionalism, ethical considerations, and doctor-patient confidentiality, I think it is important that any telehealth service provided is in the best clinical interests of the patient at all times. And provided that the practice of medicine is in line with the HPCSA issued documents, which are all aligned with the WHO and its strategy document, the future of telemedicine is actually very promising. With regards to medical devices and the regulations pertaining to medical devices, while many devices that have been manufactured with the objective of remote healthcare to include self-monitoring and treatment. These devices are unaffordable and not easily accessible to many people. So there will be an increase in demand, I would say, for these devices, more so in a post-COVID world. The regulations as they stand allow for approval through a process of in-depth investigations and analysis into quality, safety, efficacy, and the performance of the devices themselves. A major factor for consideration, however, is of course the cost factor involved in making telemedicine available and medical devices available, and having regard to the objectives of the guidelines, which I have already explained, and which were issued in 2014 and then again last year in 2020. So that brings me to the end, and I'd be happy to take any questions now.
Thank you so much, Natasha. Really appreciate it. I just want to open the chat really to some questions, but we have time for about one or two. But I think in the meantime, I could maybe just ask a question really. You know, what do you think our gap is in terms of our guidance? So the HPCSA 2020 guidance, as well as the 2014 guidance, you know, how much of a gap is it for us to actually meet those WHO guidance that has kind of come out? Do you think we need to put a lot of sort of things in place? You know, what is your opinion in terms of that?
I think that to a large extent, the 2014 guidelines and the guidance note have been issued in line with WHO issued documents. But I think more so with regards to medical devices and the approval, the regulations would have to be revisited. And then with regards to the practice of telemedicine, if one has regard to the document that was issued by the Department of Health as far back as 1998, you know, the framework has been provided already. There is a very big gap if one has to consider that the document dates back to 1998, but now it is merely a matter of implementing what has already been established in that framework and continuing with the pilot projects, well, hopefully on an expedited basis, so that it can be rolled out further. But in terms of the HPCSA issued guidelines and the guidance note, I do believe that it is in line and it is aligned with the WHO issued documents. Of course, further consideration would have to be given as further technology is developed, and also having regard to how long COVID will last for.
Great, thanks so much, Natasha. We have one question in the chat that's really come through.
Yes.
They said, thank you so much for the presentation. You emphasized safety and performance of products, yet the mandate of the SAHPRA of the Act also includes availability of devices. Can you comment on that?
Sorry, I don't, if you could just rephrase what you say. You say that I emphasize that safety performance of products is important, yet the mandate of SAHPRA of the Act also includes availability of devices. Are you asking me whether SAHPRA will approve the devices subject to its availability?
So I think, Simone, if you could just
elaborate,
elaborate, please, if you don't mind.
Sorry, can you hear me?
We can, Simone.
Yeah, thank you, Natasha. Yeah, you spoke about, you know, when regards to telemedicine and those aspects, and frequently you mentioned, you know, the mandate is around safety and performance and efficacy of medical products. Yet we have many imported products which are already CE marked or FDA approved, And, you know, there just seems to be, I think, a lack of gear towards making products available in the markets as well. You know, so we're seeing in many cases that our population are not actually being able to have the use of these devices because the focus is on safety and performance and the onerous regulations around that.
Yes, the regulations, I wouldn't say so much onerous, because as you say, where these devices have already been approved in EU countries or by the WHO, they gain quicker approval in South Africa. The issue is making it available to the public, well, firstly, due to funding, and you know, if one has regard to the COVID-19 vaccine and how that was made available, it was made available on an expedited basis. Clinical trials were performed, and one must have regard to the fact that even with the devices, medical devices, there's no compromise. They definitely, what it entails is that all the devices would go through a process of in-depth investigation, and experts would be consulted for purposes of actually rolling out these devices, approving them, and there's no compromise in that regard. But I think what it means that it's already been approved in other EU countries and things like that is that it already has gone through that process, and it actually is rolled out on a quicker basis in South Africa. I hope that answers your question.
Thank you so much, Natasha. I think that's all the time we have in terms of questions. We just want to take this time just to really thank you for all your insights during this presentation. It was really insightful. And we want to just remind the delegates to just please finish the session poll. And thank you very much. I think we're heading into a tea break. Over to you, Caroline.
Thank you.
Yes, we'll have a tea break now and then we'll continue thereafter.